Great. It's always fun to follow Mark and Pearl because I was pretty sure they would say everything I wanted to say. And also, I should note, I'm also co-chair with Mark on the subcommittee on harmonization. Because I don't get paid and it takes a lot of my time, I thought it was more of a service than a conflict, so I didn't put it down, but since he put it down. So, in the international side, really the issues are the same as in the US. There's IRB, there's consent, there's privacy regulations worldwide. And they're somewhat alike. ICH looks a lot like FDA. There's privacy regulations that look somewhat like HIPAA. I think really the difficulty is in the fact that the details are different. So in the IRB world, the investigators and others, we're all dealing with different requirements. So slightly different consent requirements, slightly different requirements on waiver of consent. And that's what makes it difficult. Already we have multinational research sponsors who face these international issues. And I imagine that any data sharing regulations or requirements that come out, even if they're voluntary, actually, voluntary initiatives, are going to have these same differences by international. So my one thought to you would be, to the extent we could have a harmonized global policy of some type, the better. So Mark already covered these. I guess you've probably heard about the pharma and the FPA voluntary guidelines that have come out, somewhat like the EMA and the FDA proposals, and some individual companies have started to share as well. But what are some of the international issues? I think one that Mark touched on is this idea that, although the EMA proposal, for instance, says they're only going to release the data to people in the European Union, obviously they're going to have subject data from people outside of the European Union. Same with FDA. So you've got this issue of now having subjects' data being shared, theoretically de-identified or anonymized, but being shared outside of the country. And then there's these, in the EMA proposal, they do state that the research uses, these secondary uses, should be within the boundaries of the patient's informed consent and in line with the spirit of the informed consent, which are kind of nice, positive statements, but very hard to interpret. And of course, you do have these issues of different consent forms. You look for, is it actually disallowed? Is it specifically allowed? Is it just not mentioned, and therefore you don't have to worry about it? Those are the kinds of things that we have to decide to interpret. And of course, the question is going to be who interprets that? Who looks at these consent forms? Will it be IRBs? Will it be government agencies? Will it be some kind of honest broker or honest broker committee? And so one thought, again, going back to this idea of perhaps we can have some type of shared international standard. And as Mark mentioned, the FDA has a standard language for clinicaltrials.gov. Ill-advised as that language is, it was forced by Congress, and so they had to put out some regulations. And I think they did a service to everybody by saying, here is the standard phrase you must use. So you don't have one IRB devoting half a page to it, and the next IRB saying, no, it's not important, let's not even put it in there. Right? Every IRB puts the same statement in. So perhaps something similar could be done with ICH, ICH being the most global standard for consent forms. And, there's a section already that says, the IRB should include in the consent form a statement that your data may be seen by regulatory agencies in other countries. So that's already being told to subjects if the IRBs are following ICH, doing their job. So maybe we could add something about additional parties given access for secondary analysis. Again, you stumble right into that issue of, is this really meaningful consent? Will people understand this? And what are the various parameters of the programs and the release? Another issue, kind of a small issue, but in many countries, IRBs only do initial review, and then they have no role afterwards. They don't do continuing review. They don't take subject complaints. They don't have the authority to suspend research. So to the extent we come up with a mechanism where the IRB is the party that decides whether the consent forms allow the release or whether the consent forms, or whether a waiver of consent is viable, in some countries you're not going to have the IRB to turn to. So somewhat of an issue. So again, just to go back over the challenges, what will participants actually understand in these statements about data sharing? Who's going to be the decider on interpretation and making the waivers of consent? And of course, just the danger in having a whole lot of different systems and different levels of detail will make it difficult for everybody involved, IRBs, participants. How are you going to have people track out, if at all, and what type of research? So I think the final point I'd like to make is that, IRBs feel beholden to require that there's legally valid informed consent. There's FDA and HHS regulations that say that's their role. And so to the extent we're talking about not having that happen, to use Mark's phrase, we're going to cram it down the subject's throats and they can say yes or not, right? IRBs, many IRBs are not going to see that as allowable within their regulatory duties and their ethical duties. Other IRBs will say that makes sense. And I think the final point, as far as just the IRB approach to all of this, when data comes into the IRBs or submissions, there's a triage process. So your first thing is you say, hey, this isn't even research. Next step, there's no human subjects in this research because it's de-identified or it's anonymous. Then you say, hey, maybe it fits an exemption category. After that, you say, okay, it needs IRB review. Maybe it's minimal risk and can be expedited. If not, it goes to full board. And so a lot of these requests, if they come in for data sharing, are going to go through that same triage process. The IRB administrator, the chair, is going to look at it and go, what bucket does this fall into? And to the extent you want consistency among IRBs, especially if you get to international settings, then it's going to be important that the government or some higher entity provides some guidance on the role of the IRB and informed consent. So, thank you.